This is the diseases of the nervous system. The first disease that I'm going to talk about is bacterial meningitis. It is caused by the bacteria Streptococcus pneumoniae or Neisseria meningitis. Some symptoms and signs can include fever, headache, stiff neck, and there are often other signs such as nausea, vomiting, photophobia, and altered mental status. Bacterial meningitis is characterized by an increased number of white blood cells in the CSF, sudden high fever, and intense meningeal inflammation. This inflammation accounts for most of the signs and symptoms. Then this is the bacteria Streptococcus pneumoniae. When the brain becomes infected, it can cause blindness, deafness, drastic changes in a patient's behavior, coma, or death. When inflammation occurs, swelling of the meninges stops the normal flow of CSF. This puts pressure on the underlying organs. And then this is what a normal brain looks like, and this is what a brain that is infected with bacterial meningitis looks like. For newborns and babies, they may not have, or it may be difficult to notice classic symptoms and signs. Instead, babies may be slow or inactive. They can be irritable and vomit and feed poorly. In young babies, doctors may look for bulging frontal or abnormal reflexes. These can be described as soft spots on the head. Pathogen and virulence factors. Researchers have shown that more than 50 species of bacteria can cause meningitis. This can include species of Staphylococcus and Streptococcus, as well as gram-negative enteric bacteria such as E. coli and Klebsiella pneumonia. However, 5 other species cause almost 90% of cases of bacterial meningitis. These are Neisseria meningitis, Streptococcus pneumoniae, H. influenza, L. monocytogenes, and Streptococcus A. All 5 of these bacteria have virulence factors that allow them to resist phagocytosis and cause disease. Pathogenesis. Humans inhale N. meningitis, H. influenza, and S. pneumoniae and respiratory droplets from infected individuals who may appear healthy. Babies pick up S. agallostiae during passage through an infected birth canal. Listeria is transferred in contaminated foods such as meat, unpasteurized milk, and cheese. In most cases, bacteria spread of the meninges from infections of lungs, sinuses, or inner ear via the blood. The bacteria is somewhat protected by their capsules from phagocytosis and metabolize glucose in the CSF. Epidemiology. Before the 1990s, H. influenzae was a leading cause of bacterial meningitis. An effective childhood vaccine has reduced the number of cases by more than 90% today. S. pneumoniae and N. meningitis are more prevalent because of bacterial meningitis. So pneumonia normally grows in the throats and mouths of 75% of humans without causing harm, but in some patients, such as children and elderly, where their immune responses are not fully active, and these pneumococci become bloodborne and invade the meninges. Diagnosis. A quick diagnosis is vital because it can kill within 6 hours of initial symptoms. Diagnosis is based on symptoms culturing bacteria from CSF following a lumbar puncture. 2-hour serological tests can demonstrate the presence of antibodies against N. meningitis. If a doctor thinks their patient has meningitis, they will collect blood samples or cerebrospinal fluid. A laboratory will test those samples to see what is causing the infection. Treatment. Physicians usually treat bacterial meningitis with any intravenously administered antimicrobial drug, typically vancomycin plus ampicillin. This all depends on the age and health of the patient and the bacterium causing the infection. If quick treatment occurs, it lowers the mortality rate by 15%. Prevention. The prevention of bacterial meningitis depends on interrupting the transmission of pathogens and their spread in the body. According to the CDC, they recommend vaccinations for children against Streptococcus pneumoniae, H. influenza type B, and N. meningitis. If a mother's vagina is colonized with bacteria, they will administer penicillin to the child at birth. They can also prevent the spread of Group B streptococcal infection by treating infected pregnant mothers with penicillin. The CDC also recommends meningococcal vaccines for military personnel and college students because of the close contact. Leprosy. This is the next disease I'm going to talk about is leprosy, and it's caused by the bacterium Mycobacterium leprae. Patients that have strong T-cell immune response are able to kill cells that are infected with the bacterium. This is a non-progressive form called tuberculoid leprosy. Nerve damage can also occur when parts of the skin have lost sensation. On the other hand, patients with weak T-cell immune response develop lepromatous leprosy. This is where the bacterium multiplies in the skin, mucous membranes, and nerve cells. This gradually destroys tissue and leads to progressive loss of facial features, digits, and other body structures. This development of signs and symptoms is typically very slow, and death is rare with this disease. Pathogenic and virulence factors. Mycobacterium leprae is a high G+C non-endospore forming gram-positive bacillus with a cell wall that contains a large amount of mycolic acid. This cell wall is responsible for the slow growth rate, which is the generation time varies from hours to days, and it is responsible for protection from lysis once it is phagocytized. There is also growth within phagocytes, and it is resistant to gram staining. This bacterium has never been grown in a cell-free laboratory culture. This has caused hindered research and diagnostic studies. The armadillo is the bacteria's only other natural host. Then this is a biopsy from a skin lesion of a patient infected with M. leprae. Then the bacteria is stained red. Pathogenesis. M. leprae grows best at 30 degrees Celsius, which shows that it prefers cooler regions of the body. It reproduces in peripheral nerve ending cells or mucous membranes of nose, skin cells, and fingers, toes, lips, and earlobes. This bacterium can remain alive inside infected cells for 10 or more than 30 years with no signs or symptoms, and sooner or later the body's cellular response attacks infected cells and destroys nerves and other tissues. Epidemiology. Lepromatosis leprosy is one of the more virulent forms of this disease and is becoming rare. In the U.S., most of infected patients were immigrants. The World Health Organization is trying to reduce the number of leprosy cases to less than 1%, 1 per 10,000 case in 2000. But after this, they stated that it was no longer a public health concern, and medical attention shifted towards other diseases, and leprosy reemerged. Diagnosis. Diagnosis is based on the signs and symptoms such as loss of sensation in the skin, lesions, and disfigurement. The diagnosis is confirmed by the identification of acid-fast bacilli, also known as acid-fast rods, found in samples from all affected skin. And then this is what can happen if someone is infected with this disease. Treatment. The bacteria M. leprae develops quickly, making it resistant to single antimicrobial agents. Therapy consists of administering multiple drugs like rifampicin, dapsone. Typically, treatment lasts a minimum of 2 years, but it can be lifelong for some patients. Prevention. To provide some protection against leprosy, the tuberculosis vaccine can be administered because they both are related and share antigens. Leprosy can be prevented by limiting exposure to the pathogen, which is spread by respiratory droplets, and if exposure does occur, use 2 or 3 antimicrobial drug agents that act against mycobacterium, such as rifampicin and chlorpheniramine. Signs and symptoms of botulism, and the toxin that causes botulism is also called Clostridium botulinum. Foodborne botulism occurs within 1 to 2 days of the consumption of botulism toxin in contaminated food. Some feel weak, dizzy, some have blurred vision, dry mouth, constipation, nausea, vomiting, and abdominal pain. Progressive paralysis of all voluntary muscles then begins on both sides of the body as peripheral nerves are affected and the patient remains mentally alert through the whole thing. Death can happen by paralysis of the diaphragm and the patient cannot inhale. Survivors recover very slowly. Infant botulism usually affects children under 6 months of age. This toxin is not ingested like foodborne botulism. The bacterium grows in the children's intestinal tract where the toxins are secreted. Some symptoms are crying, constipation, and failure to thrive. Infants are more susceptible because their GI tract do not have a sufficient number of microbiota to compete with C. botulinum. Wound botulism. It involves the growth of bacterium in dead tissue following the introduction of endospores into wounds. Signs and symptoms are similar to those of foodborne botulism, but the incubation period is longer, taking 4 days or more. Pathogen and virulence factors. C. botulinum that produces botulism toxin is an aerobic endospore forming gram-positive bacillus common in soil and water. The endospore forming on the ends of cells and survives improper canning of non-acidic foods such as meats, eggs, mushrooms, beans, corn, beets, peas, and some cheeses. Endospores germinate to produce vegetative cells that grow and release toxins that cause botulism into food in the jar or can. There are different strains that produce neurotoxins which affect neurons. This is the deadliest toxin. Just 30 grams would be enough to kill every single person in the U.S. Pathogenesis. Botulism toxins act by binding irreversibly to neuronal cytoplasmic membranes, which prevents the fusion of vesicles and the secretion of acetylcholine into synaptic cleft. Muscle contractions are prevented by botulism neurotoxins. This results in flaccid paralysis. This binding of botulism toxin is irreversible and the synapse is forever blocked. It may progress despite aggressive medical care, but the blocked motor neurons' axons may grow by new branches which form new synapses with muscles. Epidemiology. Around 60 cases of both foodborne and wound botulism occur in the United States each year, but only 10% death rate of hospitalized patients. The most common form is infant botulism in the U.S., with about 100 cases reported annually, and these cases result from inhalation of endospores in dust or ingestion of food. Natural honey is involved in about a third of cases of infant botulism. The mortality rate for hospitalized infants is less than 1%. Diagnosis. To confirm the diagnosis, culturing the organism from contaminated food, from feces, or from patients' wounds can determine this. Further toxin activity may be detected by using a mouse biopsy. In the lab, those portions can be inserted into the mice mixed with botulism antitoxin. If the mouse receiving the antitoxin survives while the other dies, botulism is confirmed. Botulism treatment. To treat botulism, there are 4 approaches. The first is to vigorously pay attention to keeping airways open and functional. Other processes is repeated washing of intestinal tract to remove Clostridium. Intravenous administration of botulism immunoglobulin can be used, which is composed of human antibodies against botulism toxin. And lastly, the administration of chlorophenicol or penicillin to kill the bacterium in wound botulism cases, but this is not recommended to treat infant botulism because it increases toxin release that worsens the disease. Prevention. Foodborne botulism can be prevented by destroying all endospores in contaminated food through proper canning and techniques. We can prevent endospores from germinating by the use of refrigeration or an establishment of an acidic environment, or by destroying the toxin with heat, and it must be heated at 80 degrees Celsius for 20 minutes. C. Botulinum produces gas as it grows, so a swollen can could indicate that food has been contaminated. To prevent infant botulism, parents shouldn't give a child honey if they are under the age of 1. And then the next disease is tetanus. It is caused by the bacterium Clostridium tetani. The first diagnostic sign of tetanus is tightening of the jaw and neck muscles. This is why tetanus is also called lockjaw. Other symptoms can include sweating, drooling, grouchiness, and consistent back spasms. If the toxin were to spread to the neurons that control glands and involuntary muscles, then heartbeat and irregularities, fluctuations in blood pressure, and intensive sweating result. This spasms and contractions could spread to their muscles, causing the arms and fists to curl tightly, as seen in this picture. It also shows a stiff backwards arch where the head and heels arch toward each other, and contractions of the diaphragm could cause a patient to die because they cannot exhale. Pathogen and virulence factors. Clostridium tetani is a small motile obligate anaerobe that produces a terminal endospore, giving the cell a lollipop shape. Vegetative cells are very sensitive to oxygen and live in aerobic environments. These endospores can survive for decades or longer, exposed to air, and found irreversibly in soil, dust, and human and animal intestines. Tetanospasm is a potential neuron toxin released by cells or C. tetani. Pathogenesis. Rusty nails are not the only cause of tetanus. It could also come from any break in the skin or mucous membranes that allow C. tetani to access deeper tissues. Wooden splinters, shaving nicks, and accidental sable wounds can, as well as more serious cuts and punctures of the skin and mucous membranes, can introduce C. tetani to the body. Epidemiology. The cases of tetanus worldwide have decreased from 1 million cases annually to 10,011 cases in 2012, mostly in regions where immunizations are available. In the U.S., morbidity has declined from 560 reported cases in 1947 to 25 reported cases in 2015. This decline has been produced by the widespread immunizations and better wound care. And then, as you can see, there's a decline in that graph. Diagnosis. Muscular contractions is the diagnostic feature of tetanus, but it is most often noticed after it is too late to save the patient. The bacterium is rarely isolated from clinical samples because it grows slowly in culture and it is sensitive to oxygen. Treatment. To treat tetanus, a doctor should make sure to clean the wound of all endospores. Immediate passive immunotherapy, in which antibodies directed against tetanospasmin are injected, the administration of antimicrobials and active immunizations to stimulate antibody and memory T cell production to help fight the bacterium. Prevention. The number of cases of tetanus has declined, which is a result of effective immunizations with tetanus toxoid. The CDC currently recommends 5 doses beginning at 2 months of age, followed by a booster every 10 years for life. And this is the end.